Hello and welcome. I'm Steve Clemens. I'm editor-at-large of The Hill. Thanks so much for joining us today for our forum called The Future of Healthcare, Tackling Costs and Pathways to Care. Over the next 2 hours, we're going to hear from policymakers and stakeholders about resetting the care paradigm across the United States. We're going to do this in 2 sessions with a little short break in between. But for first, I'd like to thank our sponsor, Viatris, for its support of today's conversations. Even before COVID-19 created extraordinary challenges for the nation's communities, stark disparities existed across our healthcare landscape. As we begin to chart a path forward, how should we address the social and the economic and the environmental factors that influence health and access? How should we re-examine our traditional models of care to better fit the needs of all patients while keeping costs in line? And what role does increased competition play in promoting sustainable care and healthier communities overall? We've got a fantastic lineup of speakers joining us, including senators, city leaders, health equity experts, and lots more. Before we get underway, a few housekeeping notes. You can tweet us at The Hill Events, but more importantly, the hashtag The Hill Health, The Hill Health. We're broadcasting live and we'll take your questions throughout the program. And if you experience any trouble with the live stream, just refresh the page. Do not throw your computer out the window. It will all be okay, I'm told. Our first guest is Dr. Alison Arwati, the Commissioner of the Chicago Department of Public Health. Prior to this, she worked for the Centers for Disease Control as an Epidemic Intelligence Service officer. Dr. Arwati, it's great to be with you. Let me just, before I get into like the heavy stuff, I'm fascinated because I've been reading your bio that, you work with the Epidemic Intelligence Service as an officer there. And there's this broad infrastructure of public health people that I don't think most people think exists. And I just want to give people a pathway to understand that there are a lot of folks out there focused on public health. Tell us just a little bit about your journey.
Yeah, absolutely. I think a lot of people don't realize prior to COVID that there is a large infrastructure that is built with a very particular focus on thinking about how to be prepared for and to respond to outbreaks, epidemics, and now pandemics. So I was in a training program through the CDC called Epidemic Intelligence Service that takes fully trained physicians, veterinarians, PhD epidemiologists, postdoctoral folks who are fully practicing, and then basically has them work on outbreak response and learn all the details of that. So I had the opportunity to work on the Ebola outbreaks internationally, the Middle East respiratory syndrome internationally, outbreaks, all over the state of Illinois. And so when COVID came, if there's one thing in the world that I've been the best trained to work on, it is that. So it's an example. Public health flies under the radar a lot. We think a lot about the medical care, and I am a physician. I take care of patients, but really my main interest is about how you protect population health. And one of the very few good things about COVID is that I do think it's brought more attention to the field of public health, where we think not about a disease, we think about not an individual and their disease. We think about the community, the population, and how really the community can be our patient. And we've got to create better systems and better ways that people are able to stay healthy as well as get care after they become ill.
I really appreciate how you have framed this. My friend Lena Wen, is often out there saying, hey, public health saved your life today. You may not see it, you may not know it, but there's this infrastructure out there. But let's go to Chicago and what you're doing there. And my understanding is you're working on equity zones. I've been hearing on the economic side about opportunity zones that the last administration, current administration, but tell us about equity zones and health.
Yeah, absolutely. So just as you were leading off, here in Chicago, like so many places around the country, we were seeing very large inequities in health outcomes across Chicago. If you look at them by race and ethnicity, you take all comers on average, Black Chicagoans live about 9 years less long than other Chicagoans, even before COVID. And we've seen declining life expectancy for all racial and ethnic groups in Chicago, except white non-Latinx Chicagoans. And so really what we've seen in COVID, where things have been successful, it's where we've invested in communities, really said, you are the expert in your community. How can we get you funding, get you resources, hire from within those communities? In Chicago, we didn't hire, like most places did, a call bank to do our contact tracing. We hired about 600 people with no particular educational background, but who were very good at interacting with individuals hired them through our workforce training program and in conjunction with a lot of community-based organizations, some of whom had never worked in health before. And those 600 folks have gone on to do an amazing job throughout COVID. We wanted to really create that sort of community-based health equity-focused infrastructure across all of Chicago for whatever is coming next. So we've divided the whole city into these equity zones because no matter where you are, there are parts of Chicago that are largely being left out. It's harder to access care. They're not having all of the ability to perhaps get the resources that should be available. There are whole parts of the city that are disinvested from an economic perspective. And we're really funding these networks to make their own decisions about which priority health issues they want to be focused on. Right now, they're starting with vaccine, of course. That's a very focused thing. But after that, we're using some funding that's focused on health inequities. And if one group wants to work on the breast cancer racial disparities and have that be the focus, and one wants to do infant mortality, and one wants to be focused on drug user health and figuring out how to get those folks into housing, we're really working to create those networks and be prepared so that whenever something new is coming, we're not starting over from ground zero. We had all kinds of equipment here, all kinds of materials, N95 masks stocked. We were in so much better shape than a lot of the country in terms of the things related to preparedness, but that community infrastructure and a trusted group to be able to really carry those messages and work on keeping people safe outside of a pandemic is where we saw we're lacking. And so it's really our plan going forward to do most of our community-based work through these networks.
Sounds incredibly fascinating. And Dr. Arwati, I'm probably going to screw up how I ask this question, but, are you able to kind of monitor over time, I don't know, some measures in health to sort of look at what the impacts are? At the end of this show today, at the end of this summit, I have an interview with Senator Bill Cassidy. Folks, I already did the interview, so I know what we talked about. One of the things he talked about, he worked for 25 years as a doctor in like the prison system and, low socioeconomic status patients that needed different kinds of support. And he basically talked about a program that he's supportive of called Connected Moms. And it's to try to address maternal mortality differences across racial lines in which there's, an absolutely horrible level of maternal mortality in the Black community, for instance. And so they're looking, and we talked a little bit about how you're going to measure over time whether you're going to be able to change this. So I guess I'm interested in models that work, and then show and tell, and then how can a lot of other folks replicate it so we find ourselves in a better place down the road. Any thoughts?
Yeah, absolutely. So here, even before COVID, we had set as the focus for the city the 5 main drivers of our racial life expectancy gap here in Chicago. Wow. Starts with chronic diseases, includes gun-related homicide. Number 3 is infant mortality. Maternal mortality is listed in there. With and then number 4 is the infectious diseases, HIV, and then now obviously COVID and other infectious diseases. And number 5 is opioid overdoses. And those are the focus. We do not define success when we are looking at how well we are doing as a city as what's happening to the average. Obviously, we want to see smoking rates go down, but we don't define success of did smoking rates go down. We say which group, whether that's a geographic group, a racial ethnic group, a socioeconomic group, a sexual orientation group, is furthest from the goal. And seeing improvements in that group toward the mean is really how we now define success in a true equity-focused way. And so even if you look at something like COVID vaccine, of course, we're watching where the whole city is going, but our primary focus is on the neighborhoods where our vaccine uptake remains lowest. And we judge our success on what is happening in those spaces, really not leave people behind. And we've been working to make sure, for example, that every single person in the city of Chicago can call a number and we will bring vaccine to your house for free, no questions. And it turns out that's actually a very cost-effective way to deliver this vaccine because you can have the individual conversations. You can build that trust. We like to bring together a group. We sort of vaccine and dinner together. And it's actually turned out to be more cost-effective, even though we thought it would be more expensive than a lot of the community pop-ups. And so I think this ability to actually look at your data, not start a program and wait 5 years, but every few weeks or months say, what are we learning here that's different? What's different in terms of cost? What's different in terms of access? That at-home program is the most popular in some of the parts of the city where access is lower. We have more Black Chicagoans than any other group taking up that particular route of accessing vaccine. But I think we could model that for so many other things. There's lots of data. You just have to look at it, and then really think about how do you not just admire a problem, but actually act on it and then evaluate that. If it didn't work, try something else. And COVID's been a great opportunity here in Chicago for us every few weeks in partnership with community to say what's working, what's not, and how do we adjust it. We want to do that for these other health inequities as well.
It's so cool talking to you. I wish you were a legislator, because then you could come and kind of, we could be out here in D.C. and then kind of, wrestle through some of these issues. But I guess the final question I have for you is along the lines of cost. You've talked a lot about cost. Yesterday, the Hill sponsored a forum dealing with diabetes and obesity, and I learned a lot about continuous glucose monitors and all sorts of new things that have hit a disease, couple diseases stacked up against each other, where there hasn't been a lot of development. But if you talk to folks across, again, the line of who benefits in America's healthcare system and who doesn't seem to be, cost is an issue for them. So how do you get around cost? And from your perch, which I know you're not making the decisions at the federal level, but from your perch, when it looks to the market on access and cost and competition, what are some of the things out there you think we need to know about when you're dealing in the field of cost and access?
Yeah, so right off the bat, I would start with recognizing that right now we put 1 or 2 pennies of every dollar into that preventive work. Much more of it goes on the treatment side. So, continuous glucose monitors, all of these advancements are amazing. Being able to actually fund a little more on the front end to actually help people keep from getting diabetes, or when they have pre-diabetes, what sort of investments and access can you work on at that point, actually is not where we typically fund, but it has the ability in a very cost-effective way to bring down some of those medical costs. The other thing is that we are, as you know, really just about the only industrialized country that has attached things like access to healthcare and insurance, either to job status, or to age with limits, or to low income. And that does leave a lot of people out, especially where you're talking about some of these amazing advances. I see patients in the largest free clinic here in Chicago. We see people who are not eligible for insurance. And boy, it is really challenging to know that there are amazing opportunities out there for treating their diabetes. And the clinic does a lot of work to make sure they can at least access the insulin, you can get these pieces in. But we have not built a system that recognizes, from my standpoint, healthcare is a human right. We've got to invest more on the preventive side, but then thinking about what is a baseline that regardless of whether you're working a job that gives you health insurance, you're actually able to access at least the basics, I think is something that is just incumbent on us, because those folks go on to have diabetes hospitalizations and much higher costs overall. And we treat people, at the other end after they've had a major heart attack, and you've got to go in and sort of pay for all of that care, where there's so much less expensive care available, but it's at the earlier preventive and often in the public health space.
Well, can I just tell you what a pleasure it is to talk with someone that I actually understand what you're saying. I can hear what you're saying, and I think the layperson out there can understand what you're saying. Thank you so much for joining us, Dr. Alison Arwati, Commissioner of Chicago's Department of Public Health. It's really been great speaking with you today.
Thank you so much.
It's time for the sponsor perspective portion of the program. Joining me now is Michael Gettler, the Chief Executive Officer of Viatris. Before we begin, a quick clarification. While I'm conducting this interview and the questions are mine, the content of this portion of the event should not be considered editorial. We're going to still have a good time and ask you tough questions. I want to just ask you, Michael, we've gone through this really weird time, and we're actually not through it, on COVID-19 and its impact. And I'm interested from your perch what we've seen by way of what we should be learning about society. How has this hit different communities differently? Should we be thinking about how we deliver health care differently? What's on your dashboard when it comes to what we've learned from COVID-19?
Yeah, thank you, Steve. And look, this is actually a question that's very apropos for us, because you have to remember that Viatris was actually born in COVID. So we really got a unique vantage point on the situation. And To me, the pandemic really reinforced why we created Viatris in the first place, because access to high quality medicine is absolutely critical. Disparities still exist. And if anything, COVID actually made it worse. And so two things I want to point out that speak out to us. One is the importance of really strong, resilient supply chains. They need to be maintained, they need to be protected, because access is not just about affordability, it's about actually getting the product in the first place. You open the newspapers, every day you read about supply chain shortages, whether it's toilet paper or microchips for cars or iPhones or you name it. This industry, the pharmaceutical industry, I think has fared better than others because there was such a focus on it. I can speak for our company. We had service levels in 2021 so far that are at or above historic peak levels. And we were able to do that because we have multiple manufacturing facilities across the world. We started out Viatris with over 50 manufacturing facilities around the world, and that helps us to ensure continuity of supply. So that's one aspect, is the supply chains that need to be protected. Another one is just different ways of working together, working in the virtual world. We had to learn that as Viatris. We combined two companies, the legacy Upjohn division and Mylan. And a lot of our colleagues that are working together every day have not been able to meet in person ever. So we had to find different ways of working. But it's not just within the company, it's with our partners, with suppliers, with our customers, with regulators. We need to learn how to do that. And I think one of the important things is that everybody uses the tools that are available to them. One of the important tools is the authority Congress has given for the FDA for remote inspection of foreign facilities, because travel is limited. And in reality, that's important to maintain a good global supply chain, to maintain access, because there's a backlog. There's a backlog of inspections, and that backlog could threaten potential future approvals or patients' access to medicine. So these are just two of the lessons I would highlight, Steve.
Well, one of the things I want to share with our audience is that Viatris is a new name out there, but it is a huge, sprawling, transnational company. My words, my sense of it is that people don't know, you're all over the place, all over the world. And as you say to people, you want to help people at every stage of their life live a healthier life. What does that mean to you? When you kind of talk about supply chains, I mean, you have a lot of different boxes you have to check off with people when it comes to care. But I was interested in this statement about helping people at every stage of life. What does that mean to you?
Well, that's actually what we're all about. That's at the core of our mission, is to empower patients worldwide to live healthy at every stage of life. And we do that independent of geography or independent of circumstances. That's what really motivates and empowers and drives our 30,000 employees across the world. And we're passionate about it. We're relentless about it, about the improving access of patients. Now, what are the ingredients? The ingredients are, number one, you have a very diverse and robust product portfolio. We have generics, we have brands, we have biosimilars, we have complex injectable, complex products. And that's important because we purposefully designed it this way so we can address a variety of healthcare needs in the US and around the world. Secondly, you combine that product diversity with a global scale, as you said, with 165 countries. So it allows us to think globally, act locally, think locally, whichever way you want to say it. You combine that with scientific capabilities that we have. We're passionate about breaking down barriers and innovating in manufacturing, making high quality products. Product safety is very important. Again, it's all about access. And then I mentioned our workforce of 38,000 colleagues around the world that are passionate, united by that mission, of doing good things, but also as a company and doing well because of that. And it's starting to be recognized. I'm happy to hear you here talk about it. We recently were recognized by Fortune magazine on their very famous, Change the World list. We're one of the top 5 companies in the world to be mentioned on the list for the work that we do for HIV and AIDS over the last 10 years. And we were also named by Forbes magazine recently as one of the world's best employers. So we're starting to be recognized. It feels good. But what drives us is really that passion about access and empowering patients worldwide.
Well, congratulations on that designation. We're at the Hill, and the Hill's watchers and readers are generally interested in public policy questions and politics. And I guess, the big question I want to, ask is, as you're kind of looking at this from your perch, and I should tell our audience, the healthcare system is very complex. There are a lot of players in it, but government matters. And I'm always interested in asking somebody in one corner of that sandbox what they think the other side could be doing to improve healthcare for patients, putting patients at the center. And so from your perspective, what advice would you give to government as by way of being able to generate better health outcomes for patients?
Steve, look, we're all about access, right? As I mentioned, that's what drives us. And I think what policymakers should be focusing on is where healthcare is going and not where it has been. The US particularly has been a leader and is a leader in access to high quality, affordable generics. You know, the Hatch-Waxman Act of 1984 has been a game changer, and striking the right balance between innovation, encouraging new medicines to come to market, but then also competition that brings prices down and expands access enormously. If you look at small molecules, that has been extremely successful. US has 90% utilization rate of generics now for small molecules. But the science is evolving. The world is evolving. The policy needs to evolve too, and policymakers need to take that into account. And I think one of the examples for that is if you look at biologics. Biologics are very, very important part of healthcare now. 8 of the top 10 products by spending are biologics. If you look at the 10 most expensive Medicare Part B drugs, they're all biologics. And there's no sign of that stopping. If you look at the pipeline going forward, maybe half of the products that have breakthrough designation are now biologics. So it's an important part that trend continues. And the regulatory pathways are working. You get biosimilars approved now, right? But let me give you some statistics. There's 30 biosimilars approved in the US now. Only 20 of them have launched, and only 5 of them have a market share of more than 20%. So you contrast that with the 90% utilization in small molecules, and you immediately see the problem. And the problem is because competition is not uniformly supported. And now the good news is I think Congress is aware. There are multiple bills out there that are all aimed at aligning the interest of patients, of healthcare providers, of payers, aligning towards the increased use of lower cost biosimilars. And we support all of these ideas. They're all helpful and will help improve access for patients. Yeah,
clearly competition matters. Let me just ask you finally, and I like this statement. I was looking up things you've said, and one of them, I'll say, in foreign policy, I do a lot of foreign policy stuff. They always say, don't look at the world as you hope it will be, but look as it is. You've said that Viatris was created with a vision to see healthcare not as it is, but as it should be. And I'm sort of interested, as you look at Viatris's role in also doing better, reaching that patient, being different. What are some of the big elements of that playbook?
Yeah, look, any kind of policy change, any kind of change takes a village, right? And different players have different roles to play. I think one of the roles that we as Viatris can play is to provide knowledge, because that's what policy makers need. Knowledge, technical knowledge we have, medical knowledge. You mentioned look at the world, so international knowledge, like what are policies in other countries that are working, what are the unintended consequences, etc. And we can really bring that to bear. We communicate regularly with local constituents, with policymakers, with HCPs, with non-government organizations, but very importantly, with patient advocates, because ultimately it's all about patients. And doing this, I think, is even more important with the backdrop of the pandemic. And I believe Viatris can really be a credible partner, because remember what I told you about our diverse pipeline. We have 1,400 molecules. We're not focused on a particular therapeutic area. We're not here to push a particular product. Our goal is to improve access and have better healthcare. And I think that makes us a credible partner. It connects us with policymakers, a shared vision for making this a better world. And bottom line is access is part of everything we do. We're passionate about access for our patients, not only for high quality drugs, but passionate about breaking down those barriers, breaking down regulatory barriers, legal barriers, supply chain barriers, whatever they are. And that's what we mean by empowering everybody to live a healthier life, independent of geography or circumstances. So Steve, you will hardly find a more passionate partner than Viatris.
Well, Michael Gettler, Chief Executive Officer of Viatris, it was really great speaking with you, and I want to thank you so much for supporting today's important conversations.
Thank you, Steve.
Now we're joined by 2 experts working to advance access and affordability in healthcare. Dr. Gary Puckran is President and CEO of the National Minority Quality Forum, an organization working to ensure high-risk racial and ethnic populations receive optimal care. And Dr. Patrice Harris is CEO and co-founder of eMed, a digital point-of-care platform with a mission to democratize healthcare by expanding access to at-home diagnostics. She's also former president of the American Medical Association, and I talk to these 2 people quite a lot, and so it's really great to see. So Patrice, I think as we think today, and our job is to get out of the rut we've been in and how we are delivering healthcare to some degree in this country. And I sort of divide the world. There are incremental things you can do. There are strategic leaps you can do. They're earnest directions, and then I call their bank shots. And I'm just interested, as you sort of look at getting a fairer and more just healthcare system, what to you are the sort of opportunities out there for achieving greater equity and greater access across all communities, particularly those communities that have been underserved?
Well, I think there are great opportunities as we think about digital care and virtual care. But whatever the mode of care, we are going to have to be intentional about addressing issues around health equity. Heretofore, we had a small amount of folks who were working in health equity and really appreciated the impact of the structural determinants of health, the social determinants of health. But with COVID, everyone was unfortunately able to see these impacts. And so what we will have to do going forward is to be intentional to make sure that we center equity in policy, in practice, that we look at our structures and all of the determinants of care that heretofore have caused care to be inequitable, and then go from there. But we have to look at systems, we have to have candid conversations, and we have to continue to act with intention.
Dr. Harris, before I jump to Gary, I want to ask, as you're in the E area, one of the areas I've been interested in is telehealth and, the kind of digital platforms we've all been shoved onto, some reluctantly, some very willingly, but, we're there now. Is there a way to, I don't know how to call it, rewire the health social contract with the fact that we're there now and overcome, I'll just call it out what it is, some of the systemic racism in our system with this? Or are those systemic racist elements reflected, as you see it right now, in our digital platforms?
Well, we've seen thus far, first of all, we are early in this, right, in the virtual digital world, but we've seen already what happens when people don't act with intention around health inequities. I think we've seen algorithms and other issues where they worsen health inequities instead of improve them. And so, right, it's about the technology. There's promise, but there's peril. And so that's why we have to, at the very beginning, be proactive about thinking about equity. And that means that the people around the design tables, the people in the rooms thinking about technology and innovation have to be a diverse group of stakeholders, and they have to make sure that equity is valued not only in word and proclamation and declaration, but also action. And there have to be metrics around equity as we are developing and looking toward this new world of digital and virtual care.
Well, thank you. Well, I'm talking to Dr. Gary Puckrin, just about every day lately, and something he said to me yesterday is one of the questions I posed to the Commissioner of Health in Chicago, and it had to do with, we can do a lot of these things, but there are a lot of, speed bumps to access. And Gary, I'm just interested, I raised your cost issue with Dr. Arwati, when we were talking about how cost is a real issue for people. And they find their way, not getting the health care they want because a lot of folks are immune or buffered from that, but the real world, that's not the case. But I'm interested in what you think we need to be doing to look at cost, competition in the health marketplace, broadening access. You've been at this for decades. What aren't we doing that we should be?
I would say, really, the first question that we should be asking is not cost, but patient risk. How do we build a healthcare system that manages patient risk? That's the purpose of the healthcare system, to keep people out of the hospital, keep them from the emergency room, keep them from disability, keep them from dying. Cost is secondary. And our problem right now is when we talk healthcare, the first thing we want to do is talk costs. And that confounds everything because we can't allow ourselves to even imagine what the 21st century is going to be like. We're not in the 20th century. We're in the 21st century, where we have new science and technologies and capabilities that we're not unleashing. And until we do that, the system is failing, right? The system is absolutely failing the American people. We can go faster. We can conserve lives. We can build quality lives. But if we're going to get in the rut and just talk cost, we lose sight of really what the opportunity is.
So what's the game changer, Gary? I mean, on this, we talked yesterday a little bit about clinical inertia. It's a new term I hadn't really thought about. But I mean, basically, audience, it just means that you got kind of a frozen state of, what doctors and health providers may be doing to deal with some ailment in which there may have been a lot of progress. So clinical inertia is intriguing to me. How do we get beyond clinical inertia, get to a point where you're thinking about managing patient risk, which is, a different way to frame it?
Well, the inertia, and I would even talk about systemic inertia, because the whole system itself is frozen because of the over-focus on cost. Every American who goes into the healthcare system believes that the healthcare system is there to lower their risk. I don't know of anyone who goes into the healthcare system expecting the system to elevate their risk. And the system is doing that, right? We have to be honest with ourselves. Our healthcare system right now is elevating risk because we are so focused on cost that we've absolutely lost sight of the purpose of the healthcare system. So once we do that, once we understand that the real job here is to help patients lower their risk, we can open up all the technologies and capabilities that we have. And what's going to happen over time is that costs will come down, because guess what? We have something like, we could find a cure for hepatitis C, which of course we have, and nobody's getting access to it because of cost, right? So if you look at the landscape and what's happening, the technology is growing. Its capabilities are growing. We're moving towards cures, but we're doing it at a snail's pace because we have all of these barriers set up in place, because the system is actually more worried about financial risk than it is about patient risk.
Well, thank you. Patrice, let me ask you a complex question, and I'm going to try to be sensitive. I don't quite know how to get it out. When you were head of the AMA, and you and I talked way back then when you were head of the AMA, the American Medical Association, and our conversations were about health equity. And, honestly, we had done this event a while back in Baltimore, and we had Johns Hopkins there and various community people, and we had incredible folks, and we had patients that were there, and you could just sort of feel in the room a big gap between patients who were most in need and all of this infrastructure around them in the area, and also a kind of, I don't know what to call it, a lack of trust, if you will, between some of those patients and their families and extended families, because they didn't see people like themselves as doctors in the healthcare system, not to the degree that they should. And so you and I have talked about this many times. But I am bothered by the notion that Patrice Harris, who happens to be a person of color and president of the American Medical Association, so she's going to be the one to deliver on equity in healthcare. Why shouldn't we expect that from every president of the American Medical Association? Are we making mistakes saying, only people in community of color can care about that? I mean, I'm just interested in friends and allies and how you see this challenge. Is that a fair question?
It is a fair question, and you should be bothered by that, because that's not the way it should be. Heretofore, it has been, and we talk about in some ways the minority tax or the diversity tax. I think if we're honest with ourselves, it has been the folks who have been most affected, who have been on the committees, who've led the efforts. And so whenever I talk to institutions, organizations, Fortune 500 companies, I say the CEO, the leader of the healthcare institution, the hospital, the Fortune 500 company, the small business has to own equity. And it cannot be the diversity, equity, and inclusion person or committee. And so that is I hope the new paradigm, as you said. The people who are leaders have to own this. I say boards should hold your CEOs accountable. There should be metrics. And the CEOs of organizations should hold every one of their direct reports. There should be performance metrics in their evaluation around equity. And the person assigned can be the quarterback and lead the team, but leadership has to own it. And so I hope that is the new paradigm shift, because I will tell you that those of us, I am obviously a woman of color, we are exhausted. because it's been on us up until now. We've got to change that.
Well, you and I've always loved our conversations about this, and we have a group of diverse dinner, but I just sort of feel like you're carrying a load, but Gary as well. But Gary, let me ask you another question here, because we are realistic. I'm going to be very careful. We're not out of the COVID crisis. We're still in the middle of the COVID crisis, folks. So don't get this wrong. But I'm just wondering that as we've done this, Gary, and as we've reached out to communities who have been disproportionately hit very hard by COVID, infection rates, out of work, deaths. Have you seen anything that you thought was good by way of new, different steps of reaching these communities that we weren't doing before in other health challenges? Like, is there anything to learn from, or did we just screw that up too?
Actually, I think, COVID turned out to be a crucible for the American healthcare system. The system that's coming out of COVID is very, very different than the system that went in. And one area I would call attention to is really how we transmit health information. One of the things that we did not do at the beginning of this crisis is to help people understand how those vaccines were going to be made and they were safe. When we use language like we're going to expedite the delivery of these vaccines, we're going to go at warp speed and all that, it confused the American public. They don't understand what the heck you're talking about. You used to do 5 years to get a vaccine, and now you're telling me you can do it in 6 months? We have to do a lot better job at bringing the American public along as we innovate, because this is not going to be the last time that we have innovations in healthcare that really transform the way we deliver care in terms of the electronic and digital health and all that, as well as the type of medicines and therapies that come on stream. So I think one of the lessons learned is really we cannot leave the public behind as we develop these new science and capabilities. And then obviously, the whole issue of disparities in care became visible to everyone as we saw those disproportionate outcomes in minority and rural communities too, I would add. And that is set off fireworks all along the system as we begin to try to come to grips with why is our system not performing as well for these communities. So a lot of changes have occurred and will continue to occur as we come out of COVID.
Oh, thank you. Patrice, just as we wrap up, I want to hear about two things. I want to hear about what are your ideas for getting the costs of care down, getting more people lined up so that they're under the tent of care. And second is just give us a snapshot of eMed. I mean, I saw you when you were just launching this, and I know you're down in Florida, I think, which I'm very jealous of. But tell us a little bit about eMed and how's it going, but also kind of give us the Patrice Harris list of on cost and access.
Well, first of all, I'd like to point out something that Gary said, and we always lead with cost, but we should not ignore cost, but we also should think about patient outcomes and what's best for patients, and start there, and then figure out how we can have a no wrong doors approach and a proactive approach and a preventative approach, so that we are diagnosing early, and that will reduce costs, right? So I think if we think about that, that will reduce costs. And eMed, yes, thank you for asking. We are a Miami-based company, and we thought about care and cost, right? Because we are thinking about the future, digital points of care. How can we diagnose early, get to any action or intervention early? And again, that gets to that quadruple aim. So I'm very excited about our work. We started out with COVID, but we're thinking about how we can eMed the world, as we say, and think about earlier diagnostics, which would lead to better outcomes and decreased costs.
That's great. Gary, I want to come to you, and you're sitting here with me in Washington D.C., and we're both in this world here. I think you're in Washington, right?
I'm in Washington. Yes.
Yeah. So sorry. Yeah, we don't have Florida down here in Miami, but I do want to ask you, as you look at how healthcare is evolving, and it's something I asked some people yesterday. In your gut, with all the different moving pieces, do you feel like we're beginning to get some of the equity challenge right, or are we falling backward? Are we stuck in a rut? I'm just sort of interested in where you think the tilt right now is going, because we've been discussing this for a long time. I wish there were a quick fix, but the complexity of it is astounding. But I'm just interested in, it's always important to take stock of whether you see some pieces moving in the right direction.
Oh, I think we are moving clearly in the right direction. When we started 20 years ago looking at health disparities, we were on an island by ourselves. The largest system was not paying attention. And now the largest system is paying attention to issues related to disparities. But I would broaden it and say, looking across at all populations, not just African Americans, but Native Americans, rural communities, I think the system is coming alive. It'll be a slog, though, because it's a big battleship. It takes a long time to turn it around. There'll be, failures and successes along the way. But we ought to be confident as we move deeper into the 21st century, our ability to cure diseases will increase, will grow exponentially. And the challenge is we have to keep pace. Our healthcare financing and delivery system has to keep pace with the science. And that's where the big change is going to occur. When our financing system and delivery system keeps pace with the science, I think we'll grow like with computers, right? We started in the 1970s with personal computers, and look at us. We're in the middle of the digital age. Well, that's what's going to happen in medicine, right? We're going to grow exponentially, and I have great confidence in that.
Well, as I'm waiting for the congressman to get lined up, I've got a little bit more time, so maybe ask Patrice another question. We have a question from the audience. It's really about, Obamacare, and the person has the impression that Obamacare is not what it should be, and how should we fix it? And I'd be interested, from a former president of the American Medical Association perspective, as you look at some of the gaps in Obamacare, what are some of the things that we should be talking about?
Well, certainly, as you note, that the American Medical Association was very supportive of the Affordable Care Act, but I view it, Gary, that it wasn't realized to its fullest, right? After some court decisions and other legislative rollbacks, it wasn't realized fully. And one of the key areas, I think, is Medicaid expansion. And I have to tell you, as a psychiatrist, that is so critical because, Steve, you're going to have a symposium about mental health, because that is, we're seeing a lot of trauma and a lot of issues. But I know
Absolutely.
that so many people have been able to get care for substance use disorders and mental disorders because of Medicaid expansion. And so we need to continue to make sure that everyone has access to affordable, meaningful health coverage. We can debate about how to get there, but I think that is a shared end result. And we have to, Medicaid expansion is just a piece of that. And then we have to look at, as Gary said, financing. We want to make sure we are financing the right things, right? Because sometimes in our financing models, there are disincentives to integrate care and do a lot of other innovative things. So I think it's about Medicaid expansion, looking at regulatory issues and making sure that our regulatory framework doesn't impede care, and look at other rules and regs that really impede innovation.
Well, look, we're going to have to leave it there. I really appreciate Dr. Gary Puckrin, Dr. Patrice Harris. Of course, Patrice Harris Gary Puckrin is president of the National Minority Quality Forum. Dr. Patrice Harris, co-founder and CEO of eMed, former president of the American Medical Association. It is always a pleasure to talk to the two of you. And Gary, I guess I'll be seeing you tomorrow somewhere. So thank you so much for joining us today.
Thank you so much.
Take care.
Well, that brings us to the end of our first session today. Thank you to Viatris for its support, and to all of you attendees for joining us. We're not done yet. Take a quick stretch break, refill your coffee cup, check up on your work email, and we'll be back here shortly. We're going to hear from Andy Slavitt, former senior advisor for the White House COVID response team, Senator Bill Cassidy, and many, many more. See you at 2:15.